I would like to thank Dr. Muralidhar as well as Dr. Balani and the organizers of this wonderful webinar for giving the opportunity to come here and talk to you about advanced imaging for congenital heart disease. I have no financial relationships relevant to this talk. I am a pediatric or congenital interventional cardiologist, and what I'll be talking about is advanced imaging for helping with interventional and or surgical planning in patients with congenital heart disease. And it is important to understand that it's a complex three-dimensional anatomy that is hard to understand on a two-dimensional platform. More so, for interventional planning, it is very important to understand the adjacent relationships of structures. As we see here, the aortic root and the coronary arteries to the pulmonary artery, and or even the extravascular structures like bronchus as shown in this diagram. So what I'll do here is I'll show you some case examples to depict how we utilize different cross-sectional imaging like CT, MRI, 3D rotational angiography, 3D prints, ecopixel, and even virtual reality nowadays for planning some of these cases. The first case example is an example of a ductal stent, and we are talking about ductal-dependent pulmonary blood flow as seen in children who are born with obstructive lesions of the right ventricle outflow tract, such as in tetralogy of Fallot or pulmonary atresia and intact ventricular septum. So these patients, they are dependent on the prostaglandins in the first few hours of life till there is an alternate source of secure pulmonary blood flow established. Conventionally, this had been in the form of a modified Blalock-Taussig Thomas shunt, which is basically a Gotex tube graft from one of the subclavian or the innominate arteries to the pulmonary artery, as shown in this diagram. And the surgeons usually tie off the patent ductus arteriosus. What we have realized nowadays and proven and published that we can actually put a stent in the ductus arteriosus and keep it open and therefore avoid invasive surgical operation for these critically ill newborns. This is an example of one of the patients that I have who was born with prenatally diagnosed pulmonary atresia. As you see that the cross-sectional imaging is good, but again, the two-dimensional imaging has to be formatted in multiple planes and understood in multiple planes to understand the anatomy. So it's hard, it's relatively hard. We show you the same patient with a 3D reconstruction, which you can rotate. It's very easy to understand that this patient probably has a right aortic arch with mirror image head and neck branching, and there is a large tortuous ductus arteriosus which rises from the underside of the arch and feeding the confluent bilateral branch pulmonary arteries, as you can see there, with mild hypoplasia of the right pulmonary artery. What is even more important is to understand the relationship to the adjacent structures as I was talking about. And in this case, as you can see, the ductus arteriosus, it kind of rests right there on the right bronchus, and there is mild narrowing of the right bronchus. This is very important to understand so that you can understand what would happen after the intervention if we do a stent in this ductus arteriosus. We predicted that as we stent the ductus arteriosus, it would be lifted up away from the bronchus, and so it should be safe. So this was the baseline angiogram that we performed through a percutaneous carotid artery access in the right common carotid artery. Again, demonstrating the confluent branch pulmonary artery supplied by a tortuous patent ductus arteriosus. This patient underwent a placement of a coronary artery resolute onyx, which is a drug-eluting, so tacrolimus-eluting stent in the ductus arteriosus, and subsequently underwent superior cavopulmonary connection, also called as a Glenn operation, at the age of 4 months, which was uneventful. He had a CT scan, which was performed at subsequent follow-up, which again demonstrated that after the placement of the stent in the ductus arteriosus, the right bronchus, as demonstrated by the area, remains unobstructed, and the ductus is lifted, as we predicted, the ductus is lifted away from the bronchus. So the pre-op imaging was very critical in this case. One, to help assess the access site, which was the right common carotid artery, which made the procedure relatively simple and very fast. It took like half an hour for this procedure from sheath from sheath in to sheath out time, which was all possible because of the preoperative planning. Another example that I like to show you is the transcatheter pulmonary valve placement. And this case example will show you the relationship of adjacent vessels, in this case, the pulmonary artery or the right ventricle outflow tract, and the aortic root and the coronary arteries. So this is an 8-year-old patient who weighs 23.5 kilos. She was born with tetralogy of Fallot as a newborn and underwent a transannular patch repair for the tetralogy of Fallot. And she subsequently had free pulmonary valvular insufficiency, as you can see here on the angiogram on the left. We know that putting a stent in the pulmonary artery can cause aortic root distortion and or compression of one or the other coronary arteries. And we did what is called as a balloon testing, but it was inconclusive. The left main coronary artery seemed close to the balloon, as you can see on the angiogram on the left, on the right. So what we performed was a 270-degree spin of our C-arm in the cardiac cath lab with the balloon inflated in the right ventricular tract and angiogram performed in the aortic root as shown on the left. It gave us immediate reconstruction of the aortic root and the coronary arteries, as you can see here with the balloon inflated being there. And you can rotate, and once we saw that there is still the balloon still maximally inflated. There was still sufficient amount of space that made us feel comfortable for the transcatheter pulmonary valve placement. She successfully underwent a placement of 26 millimeter SAPIEN-S3 valve in the right ventricle outflow tract. And as you can see, the angiogram of the right, there is no more pulmonary insufficiency. And we tested the coronary artery, and as we predicted from this rotational angiography, there is no coronary artery compression, although the left main coronary artery was again close to this thing. As I highlighted earlier, the relationship is not only important of the adjacent vascular structures, but it is also important to keep an idea of the other non-vascular structures, for example, the bronchus in this case, when stenting the pulmonary artery. It has been very well described that we can have bronchial compression. We have seen unfortunately in one of our patients as well, that once you stent the pulmonary artery, it's the same real estate that's present for that. It's the limited real estate inside the chest, so they can happen a bronchial compression. This is a nice depiction in this paper by Dr. Graham, which showed before and after inflation of a balloon in the pulmonary artery, and they did a bronchoscopy to demonstrate the bronchial compression. This is a patient of mine who had a hypoplastic left heart syndrome, so underwent a single ventricle palliation. You saw the ductal stent or BT shunt at the first stage, or the Norwood operation at the first stage, then superior cavopulmonary connection with the Glenn operation, and then the Fontan completion. This is an extra cardiac conduit, Fontan conduit. As you can see, there is some streaming of flow from the superior caval vein to the left pulmonary artery here, and there is left pulmonary artery stenosis. So nowadays we perform the 3D rotational angiography in the cardiac cath lab with immediate reconstruction of both the airway and the pulmonary arteries, as you can see here. And again, we can demonstrate that there is stenosis of the left pulmonary artery right in this region, but it's fairly away from the bronchus. And on the measurements on the intended stent placement, we anticipated that it should not cause bronchial compression. This patient underwent successful placement of stent in both the left pulmonary artery and as well as to treat some stenosis or narrowing in the Fontan conduit, and it went uneventful without any bronchial compression. So again, this pre and peri-operative imaging in the form of either advanced CT scans or MRIs, as well as rotational angiography, was very helpful in both these cases. What we have also done in some of the patients is actual production of a model of the 3D heart and 3D print so that we can simulate, even place stents inside these vessels. These can be printed in soft tissue models as well. And we have demonstrated that producing this, and we recently, one of our PhD students, she presented this work at one of the conferences, that it has been helpful for complex pulmonary artery stenting as well as transcatheter pulmonary valve replacement. Nowadays, with advancement in technology, we don't need to print a 3D model. We can just import our images from the PACS or from the electronic medical record directly to these virtual reality softwares. One of the examples is EcoPixel, and you can actually do an intended measurement or do the measurements, do an intended intervention, or see how your intended intervention would look. One of the other things that we are looking at with one of our visible heart laboratories is virtual use of virtual reality for understanding these complex anatomies. As you can see in this patient, again born with pulmonary atresia, and you can see that it's spread by a very tortuous patent ductus arteriosus. So having these models, having these virtual reality in your hand really helps you understand the complex anatomy very well before you go suggest an intervention, either surgical or transcatheter. What is next stage, which I'd like to share with all of you, is unpublished, very preliminary data that we are doing at the University of Minnesota with patient-specific finite element modeling to help predict these tissue interactions. So Carly, as shown here, and Victor Barukas, and they are both the bioengineers at the university, and what they're trying to do is take these patient CT scans and then make these patient-specific 3D models and actually simulating what we are doing in the cardiac cath lab for them. So they fixed the coronary arteries as shown in the red on the left, and then added the adipose tissue in between the blood vessels, and then enlarged the pulmonary artery in the area of the stent, and measured if there is any aortic root displacement or stress on the aortic wall or the coronary arteries. And as you can see in this case, they predicted that there is significant stress on the aortic wall as well as there is aortic wall displacement. And when we actually brought this patient to the cardiac cath lab and did a balloon test inflation, there is significant aortic wall distortion, aortic root distortion, and aortic valve insufficiency, as you can see. The image on the left shows aortic root injection without the balloon inflation, and there is no aortic insufficiency. But when the same is done with the balloon is inflated in the right ventricle outflow tract, there is significant aortic insufficiency. This prohibited us from proceeding with the transcatheter pulmonary valve placement, and this patient underwent a surgical valve. So to conclude, two-dimensional imaging has its limitations in understanding the complex three-dimensional anatomy and spatial relationships. The use of multimodality imaging, either cardiac CT scans or MRIs, if 3D prints, rotational angiography, if you're coming to the cardiac cath lab, virtual reality and EcoPixel, they may be utilized based on the need and availability. The future direction is to integrate these multimodalities, such as overlay echo and or CT images, and to simulate interventions in a virtual space. I cannot finish this talk without acknowledging my mentors and Dr. Steinberger, the division chief. And thank you everyone for your kind attention.